And welcome to this webinar. I'm Matt Ross, Editorial Director of the Publishing House Global Government Forum, which serves civil servants around the world. And today we'll be talking shapes health and care services during the pandemic to treat COVID patients, keep staff and patients safe from infection and maintain routine services. We've seen this year some amazing examples of service transformation with staff, for example, moving to remote consultations and setting up new high volume services from scratch. And the pandemic's driven collaboration between health and care providers, councils, suppliers and national governments to new levels in many countries, often accelerating progress on existing plans to integrate services, share information and improve patient care pathways. But as we get through the second wave and move towards mass vaccination campaigns, there's big challenges facing public servants. Health and care workforces are often exhausted and traumatised. Many countries have built up backlogs in diagnostic services and elective treatments. And the shift to remote consultations in primary care brings some problems around accessibility and service quality. We want to bring out the lessons that we've learned so far about how to respond to the pandemic, particularly on service transformation and integration, to consider the best ways to roll out vaccines, applying those lessons, and to explore how health and care professionals can move on from emergency or crisis response to embed the positive changes and plug the inevitable gaps we've seen in care provision. We'll begin with short presentations from our four panellists, but we aim to save about 45 minutes for questions from myself and the audience. So this is your chance to have your questions answered directly by the panel. As questions occur to you, please click on the Q&A button at the foot of your Zoom window and type them in. I will keep an eye on it and we'll get through as many of those questions as possible. Please do add a note if you don't want me to use your name alongside the question. So our panel, we have Heidi W. Steinecker, who's Deputy Director of the California Department of Public Health, where she oversees the Center for Healthcare Quality. Before taking that job in 2018, she worked as a healthcare consultant in Germany and in leadership positions at the University of California's Davis Medical Center. Indy Singh is a Director for IT Transformation and a healthcare expert at PA Consulting. That's our knowledge partner and their support that enables us to provide this webinar free of charge to public servants. Prior to joining PA, he spent 13 years in NHS England and NHSX, covering briefs including integrated care systems, public health and digital medical records. Ian O'Neill is the Director of Digital Transformation at NHSX, the Department of Health and Social Care's digital agency in the UK. After 15 years in private sector tech transformation roles, he joined DHSC in 2017 as head of its digital strategy function and then moved to NHSX on the agency's foundation. And just arriving, triumphing over his IT problems is John Restall, Chief Executive of Managers in Partnership, the UK union representing managers and leaders across health and care. Established 15 years ago, MIP is a joint venture between the unions Unison, which has a big health service membership, and the FDA, which serves civil service managers. In the interest of transparency, I will add that I've done work with MIP to help improve their digital communications. John, are you content to go first?
Yes, if you can hear me okay, and apologies for that. In the end, I relied on my own phone rather than anything provided by my employer. So anyway, delighted to be here and thanks very much for asking me to join the panel. I obviously, as Matt said, represent a trade union of managers working in the healthcare system. So I thought I would give you a perspective from our members as both managers and employees. And so my pitch is going to be largely around the workforce. But and what I wanted to do was sort of give you some headlines from what they feel that they have learned and valued and want to keep from the last 9 months or so, some of the challenges that we see going into the future, and then perhaps some of the policy responses to help meet those challenges, so that we do get something by way of the transformation of the system from what has happened. So I'll spend a couple of minutes on each and then hand the baton on. So the first thing I think most of our members have said they've appreciated and welcomed is the huge ramping up of collaboration and local freedom to do things differently, mutual aid, and some freedom from regulation, which in certainly the NHS system is an important factor. So managers, I think, feeling that they have had more to do with frontline staff and patients and less to do with regulators, and that's been something that they would like to see continue. One of the things that everyone describes as an accelerator effect of the pandemic is obviously around the adoption of digital communications for home working, telemedicine, and so on. And I think what's happened for most people is a widespread adoption, where it was more like a brake than an accelerator before, amongst both staff and the public. This has been a sort of massive moment where a lot has happened very quickly. And also with that, the third thing that everyone is talking about and wants to keep is some of the workforce flexibility that has come about and again been rapidly adopted across the system. For example, around home working, but not exclusively, different kinds of roles, different ways of doing jobs. And that flexibility, I would say, more than anything I've seen before, is being shared as much with the employee as with the employer. There's benefits for the various stakeholders from flexibility, whereas before it might have been perceived as just one way. So I think those gains are clearly massive for the services, and people want to see them continue. Having said all of that, I think there are some big challenges facing the system that our members are working in. And clearly the big one is going to be recovery. Is going to take a very long time from what has just happened. I think Anita Charlesworth last week was talking maybe 3 to 5 years before the NHS, for example, recovers from what has happened in terms of business as usual. Demands too are going to rocket as a result of both COVID and the economic impact, particularly around mental health. We are clearly not seeing the fixes to other parts of the system, such as social care. Big missed opportunity to sort out the funding there last week from the Chancellor, and also obviously infection control and new ways of working are going to affect productivity on the kinds of things that people have to do, to recover the waiting lists and so on. So we have a system that is running extremely hot. It always used to. It's going to be running even hotter, and a very lean management structure as well. And I think it's that system capacity to do some of the transformation, keep things moving in that positive direction, that are going to be really, really difficult to achieve, because people's focus is very likely to be on survival in this system rather than transformation. And I think that comes to my third big challenge, which is staff are exhausted. Matt used the word traumatized. I think that is certainly true in many cases. Some groups of staff more so than others. The black and brown staff in the NHS are probably feeling under-supported and in danger than others, but I think it's a generalized feeling. And also we were dealing with a workforce that is already experiencing widespread shortages, not just in clinical roles, but in key back office roles like tech and IT as well. So the challenges are huge for a system that is also trying to transform over the next 3 to 5 years. So I think from our perspective as a union of managers would be some asks of policymakers. I think the first one is there must be a really clear policy and funding framework that encompasses not just acute healthcare, but the entire health and care system. And beyond that, the wider public services that we know determine the health of the country. And I think, a focus simply on the acute sector or simply on pandemic management is not going to deliver the kinds of opportunities for transformation. I think the second ask, and this is very often very difficult for policymakers to conceive, I think, is they're going to have to create in a very hot system some headroom for staff and managers to do the kind of work you need to do to transform and work differently. So, you know, co-production, consultation, trying new things, taking time out, all comes at a cost, both in terms of time and money. And unless that's built in, it's very hard to see how a lot of the innovation that we want to lock in and spread is going to happen. And then my final point would be to policymakers, you've got to take the workforce really seriously now. And I think flexibility for the workforce through technology and other things is a high priority. So tech innovation has to be, you know, obviously a benefit to the taxpayer and to the public, but critically, staff are going to have to experience the benefits of tech as well. And other investment in both numbers and pay are going to be essential over 5 years to support transformation plans. So sort of glass half full, glass half empty, and how do we keep whatever we get in the glass for the next 5 years would be how I'd summarise those thoughts, Matt.
Very much indeed, John. We'll go straight through our panellists' comments if we may. So Heidi, can you tell us how things been over there in California?
Absolutely. Thank you so much for having me here today. So I wanted to cover just a little bit of how COVID-19 has really transformed not only healthcare delivery services, but also our healthcare oversight processes. And, you know, really our big goal when this started, we started our Emergency Operation Incident Command Center back on January 24th in California. And really the goal was to really focus on, you know, keeping our healthcare delivery system intact through multiple surges. I would say at this point, I really kind of break up what we have learned and lessons learned to, you know, what were some long-standing issues pre-pandemic. I would say pre-pandemic, a lot of our healthcare delivery in California, in the US, and our oversight systems of, you know, our quality and safety oversight systems are very kind of reactive or punitive, right? You wait for something to happen and then you go investigate. You wait for a scheduled or federal CMS, you know, kind of arbitrary schedule of when you enter into facilities as regulators or surveyors. A lot of our processes were paper or manual based. And there were some longstanding gaps and issues and people really not only in government working in silos, but also at different levels of government. So federal, state, and then in the states, we also have counties. So in California, we have 58 counties that have local health jurisdictions within the state. So it's really like having 58 states within a state. And so really there were some, I would say, opportunities here for us to collaborate both on the government end through different levels, but also collaboration between different departments as well, and collaborating more between the healthcare delivery system and the government. So I'd say during the pandemic, of course, obviously we had to get creative. We had to be able to solve some massive issues and problems. So of course, creating more of a collaborative approach, providing technical assistance to not only the policy that we were delivering and the constant changing policies and infection control, but also, you know, technical assistance on, you know, patient throughput and creating up surge systems with it at each county. And then post, and I would say some of our lessons that we're already, I know we're far away from a true post-pandemic, but something that we've already started to adopt that we know that we will keep post-pandemic will be using data to really drive our systems. So currently, we collect data on a daily basis in California ever since March in both all of our general acute care hospitals and our skilled nursing facilities. California is unique in the sense that we have more facilities, sometimes triple or quadruple the amount of healthcare facilities than any other state. We have over 11,169 healthcare facilities in over 30 different facility types, all in just California. We have 40 million people in California. We are the 5th largest economy in the world. So we really have, you know, a unique challenge here in California, even though we're only one state out of the 50. And so we're really using data on a daily basis. We were the first state to use data and ask all of our facilities to provide us data so we could do predictive analytics, try to predict where we would next have our next surge in a hospital, where we could possibly see an outbreak in a skilled nursing facility, and then being proactive and going into these facilities in advance, providing technical assistance, making sure they have the proper PPE, making sure they have enough staff deployed, and then be able to have kind of standardized processes across. On the next slide, you'll see a couple of pictures of really what we were trying to solve was really expecting, solving a huge surge. So on the right-hand side, you'll see what a former national basketball arena had looked like. And on the left, that's what you see, the end product of us really creating makeshift, huge hospital systems that could be able to be decompressed from, we were able to decompress our other hospitals by creating these alternative care sites. So we created over 1,000 surge beds in California at the state level, and then each county also took this same model and created thousands of more extra beds at the county level using the model that we used at the state level. We also established the Health Corps, which was a deployable group of clinicians. We're also actively working to try to get other clinicians from Australia as well, as we know that right now the US is really impacted and saturated. And I want to thank the previous panelists for noting that there is a real true what we call pandemic fatigue amongst our healthcare workers in America. And so now we're looking at, how do we take all these collective we have National Guard, CalMat teams, all of these different teams that we deploy out into facilities when they're having issues with staffing levels. And then of course we created an urgent supply incident command system where we're able to deploy out different types of PPE and fit testing for N95s, et cetera. All different types of contracting services that we can deploy out to the county level, a city, or an individual facility. On the next slide, you'll see how California was really innovative, I would say, with using technology to mitigate outbreaks. So there were three things that we did immediately. So that first large black screenshot is really our urgent needs dashboard. We created this back in April, and it serves as our daily early warning system. It basically monitors all of the data coming in in real time from all of our facilities. And then in the bottom right-hand corner of it, you see a little picture of California with little red dots. What happens is as soon as we get the data that comes into the system every day, by noon, it will flag a facility as a red dot or a green dot. That allows us to know immediately there could be an issue at that facility based on the data algorithm that we have for indicators of high risk. And we put in everything from, an outbreak that is within that same zip code or 5-mile radius. We've put in data about previous years of compliance, data of previous outbreaks or even flu outbreaks or other diseases as an indicator as well. And so then we go out on site to those facilities immediately to be able to deploy whatever it is that they end up needing. You'll also see on the far right of the slide, you'll see the blue screenshot of we created a mobile app system for all of our regulators and surveyors to be able to use. So when they're out there doing infection control surveys, they're out there checking for safety issues. That is all of that data is real-time flowed up into our system to be able to also look at metrics, look at what are the most common issues so that, again, we can then tackle those on statewide calls, statewide webinars that we do every week. And then at the bottom, you'll see the contact tracing web-based platform that we use in California for contact tracing to be able to also collect data, put it into a system, and then make that data actionable. And on the last slide, you'll see what is the impact of all of this. So on the graph on the left is really, you'll see that that gray mountain there, those are really our case rates in California. And then the orange or the yellow line were the case rates that we had in skilled nursing facilities. And of course, those are our most vulnerable patients that we're trying to solve for. And then you'll see the orange line at the bottom used to be or was their mortality rate. And so you'll see that spiked early on. And so then we immediately started to do weekly testing of all our healthcare workers. We have 90,000 healthcare workers working in just the skilled nursing facilities. Started with weekly testing of the healthcare workers, and also was the first state to require that these types of facilities create a mitigation plan. And then we go out every 4 weeks to check their mitigation plans, check their safety compliance and their infection control. All of that resulted in a huge reduction in the mortality rates, despite that the case rates tend to still follow the community spread trend. We were able to intervene early, which then of course meant less death. The graphs on the right-hand side is comparing California to other states. Now, as I said, California is unique. We have by far thousands of more facilities and hundreds of thousands of more patients and residents in our facilities. But you'll see that we're the orange line, and we're able to have far less death than any other state. I compared us to the 4 states that are as close to us as possible, which is New York, Florida, and Texas. New York looks like it's really low there, but the problem is with this data is this is the federal data, and feds were not collecting data until June. So actually, if we were to see what New York looked like back in January through May, you'd see that they already had their huge spike prior. So again, it's been an opportunity. I would say lots of silver linings for us. I would say long-term delivery systems will be changed, using dialysis in skilled nursing homes rather than having people go to a dialysis center, a lot of telehealth, a lot of looking at triage and how do we use our nurses in different capacities. And a lot of opportunities, again, to use data and technology in new ways to drive what our priorities are as far as trying to keep people safe.
Thank you so much, Heidi. That's really, really interesting. Well, we'll hopefully come back to some of that, but first let's hear from Indy, if we may.
Brilliant. Thanks so very much, Matt. And so kind of going back to some of those core key questions, I'll kind of briefly go through some of the key points within that. So in that context around the unique challenge presented by COVID, I think kind of see that in 4 different dimensions: scale, speed, clinical safety, and an unknown endpoint. You know, we had to move at a scale that I don't think we've ever had to do before, speed, but also in a way that continues to be clinically safe, and in a way where no one quite knew where the endpoint was. And I think what it did reflect is and again, the NHS is absolutely amazing when it comes to having to deal with absolute emergencies and being able to stand up and really kind of go above and beyond. I think what we have to really think about is that flick between BAU and then pandemic, and the need for the middle ground as to how do you do this in a sustainable manner. And if I'm candid, you know, I think the first wave is probably simpler than the second and potentially the third. The current wave we're in, we've now got to think about a mixture of different channels. We've got those that want to go online, those that want to do face-to-face, those that need to do face-to-face. We've got to think about, in terms of triaging, both the clinical risk, but now also the physical risk. And also through wave 1, there were clearly a set of inequalities that were probably known, but didn't surface as much as they did explicitly within that first wave, where we have to clinically look at how we address some of those inequalities, because whether it's deprivation causes or whether actually it's BME or others, these are absolutely tangible and real. And so I think we recognise that we have a workforce that has just gone absolutely above and beyond, but actually about to enter something that's even more complicated than they've just been through. And then at the same time, you combine that with an elective demand that is clearly only increasing with a significant backlog. So I do think the challenges are actually more complex going forward than they have been looking retrospectively. In terms of sharing experiences around service transformation, some of the great examples that Heidi and John talked about, I do want to look at data and digital. And one of the key themes I want to bring out about that is the need to look at the patient holistically. I think there's been brilliant progress around remote consultations, massive rollout, but actually when you look at certain patient groups or really think about their needs, this is as much the remote consultation, but wrapped around it, the remote monitoring solution, wrapped around it, the remote diagnostics. And actually, if you're not careful, if you continue with just delivering point solutions, you actually, to an extent, can make the service delivery harder, but also a worse experience for the patient. Where I think it's worked well, and just a couple of examples around that. So one's the wellbeing automated call service. This is work's gone on in Hampshire, where, especially during that time of having to deal with the interface between health and social care, where elderly patients are continually having to go in and out of hospital and care homes, how you can create a holistic digital service that allows them to be contacted effectively, allows the care pathway to be monitored. So actually they genuinely feel as if care is wrapped around them. Also, just from an economic perspective, there's significant savings around being able to use cloud-based services now as opposed to physical follow-up by people. Digital twins, some of the work at Nottingham, where you can now start using AI and ML approaches to both model the current kind of demand, but also the potential demand as well. So you can start thinking about your patient flow in between your wards and across your hospital. And then most recently, Cheshire and Merseyside, where they've looked to create an online app to be able to forecast activity across the system, because we're going to have to be much more nimble now around what's happening in terms of actuals, what's happening in terms of forecasts, waiting lists, and the system planning and the response required, because we're going to have on this perpetual cycle of changes in the posture and the scale of patients that need to be covered off. So I do genuinely think there's a key theme around service transformation, around the move away from point solutions to that holistic delivery around the patient. And related to that, I think we have to be, again, candid and honest with ourselves. Blueprints are really useful for people, but actually that's necessarily but not sufficient. At this point in time, the system is under such pressure that they actually need hands-on help to be able to implement these solutions, not necessarily just the blueprint around this is what you could think about. And so kind of closing off in terms of what I think are some of the key considerations to central government colleagues, probably three main things. One of them is, when you're thinking about service transformation, just paying for the licenses is again necessary but not sufficient. I think Office 365 is a brilliant example. Great tool, great collaboration. The investment around the national licenses, but what there wasn't was then the investment around the local business change. And actually we now have a product that is probably across the service, but actually is not genuinely being able to realise the benefits that it could do. Secondly, and kind of related to that, is if we're going to think about sustainable investment, we need to think about end-to-end services that we need to put in place, which then also means we need to think about the move away from capital funding coming down nationally to actually revenue-based funding that can create the investment around sustainable services. And then the final piece is, while we're going through this second and potentially third wave, we have the formation of integrated care systems, integrated care provider partnerships and place. And we have to genuinely understand how this is going to work to be able to create that sustainable model, both now and for future delivery of services. And I think what we have to recognise as part of that is there needs to be the investment around actually what's the operating model. We have our own digital maturity assessment that we've used across a number of ICSs. It's still really clear that operating model isn't mature yet within localities to who's doing what. But also from a workforce perspective, there is just the recognition that there are gaps within the workforce. And I don't think we can necessarily pretend that they're suddenly going to get filled over the next 6 months. So again, in terms of ongoing investment and sustainability, the recognition that there will have to be kind of mixed hybrid models of NHS workforce complemented by other skills to really be able to deal with the future complex waves that we're about to walk into. Thank you.
That's great. Thank you very much indeed, Indy. And finally, if we can hear from Ian of NHSX.
Thanks, Matt. I'm going to do what I spend most of my life trying to do, which is follow Indy and achieve somewhere close to the perfection that he is. So yeah, I mean, kind of interesting. I mean, obviously I agree with, pretty much everything that's been said before. And, there's clearly some cross-cutting challenges and some cross-cutting opportunities that we've all sort of identified and variously trying to work in. I think, some of the unique challenges, as you asked me, around, COVID and working in the wave one of the pandemic, I think we're feeling one of those challenges now, which is the sort of the remoteness of this. John's IT issues and the fact that we are, you know, we've never met, apart from India and I, you know, we've never met. You know, when you're trying to build kind of teams and collaborate, you know, there's the soft kind of people stuff that's kind of critical and can make or break, you know, transformation. And I think it's been credit to, you know, everybody in the space that we've managed to build those teams. I mean, I remember in wave one, you know, we had such a, you know, suddenly for us, such a heavy requirement for digital and technology people that we of course had to go out to the market to bring people in, right, to supplement the people that we've got. And you know, there's a lot of press about the good and bad ways to do that, but the truth is, you know, trying to create a team of, you know, 20, 25 people, 3 of whom may know each other actually, you know, most of whom have never met each other, and then kind of come around a project, deliver and make something happen, you know, is really challenging. And then of course all the other aspects of remote, you know, I mean, infection control environment, you know, even deploying technology into a setting is a challenge, right? You know, you gotta stick your stuff behind a door for 24 or 48 hours, and then, you know, you can't send an engineer in to set it up unless they, you know, unless they can, you know, work in a safe way. So very, you know, just the logistics of making stuff happen in this environment, I think, is very difficult. You know, the user research, you know, my user researchers had the toughest time, you know, because they want to go down, they want to sit next to people, they want to speak to them, they want to observe them, you know, they want to be on the front line looking at what end up on a Zoom call or a phone call like this. So you know, very challenging just to the ways that we work. And then I think probably the biggest challenge, and as you said in your intro, I mean, I'm 3 years into the public sector, but I'm mostly a private sector, you know, operator. I think the biggest challenge for us was probably the urgency. In the public sector, I mean, here, you know, we don't really have a competitor. You know, we're not trying to kind of beat someone to the punch. So in the private sector, you know, a good way to drive transformation is to tell your CEO that your rival, your competitor, is about to launch this new service, this new functionality for its customers. And if you don't do it soon, you know, you're going to lag behind, right? And that's how you get people behind your sort of transformation. In the public sector, you know, we don't really have that. It's kind of like, I hate to say this, but it's sort of like, you know, things happen when they happen, like they take as long as they take, sort of thing. And actually that was no good whatsoever. You know, we trained all these digital people to do an 8-week discovery, making sure that the minister, you know, hadn't asked them to deliver something that couldn't be delivered or shouldn't be delivered. And, you know, when you go to someone and say, yeah, great, we'll develop that for you, the first thing we're going to do is an 8-week discovery. You know, on March the 16th, 2020, you know, your bum, you know, won't hit the floor, like you'll be out of there. So we had to come up with new ways of working. And for me, that's probably the biggest challenge of it all, is, you know, how you get stuff done. In terms of, you know, experience of transformation, look, I mean, I won't echo what everyone said. You know, obviously there's a double-edged sword here, right? There's a massive benefit in the fact that at the start of the year, you know, somewhere around 3% of GPs could do video consultations. Now, you know, 99% of them have the capability. Indy mentioned, you know, it's not just about the capability though, it's about the kind of service wrapper that goes around that. So how do we go back in and make sure that, you know, we're doing that in the right way, you know? That's interesting. I think we touched upon the kind of working with the private sector. You know, that's very interesting, and we've got to get better at that. I think you know, collaboration is the key, as we say. You know, we had some good collaboration from retailers and the like, trying to help us to get, you know, food and essentials to people who were shielding, and it was a very interesting time. You know, everybody wanted to come and help and do whatever they could, but actually it almost becomes like a denial of service attack, because you've just got these kind of wave of offers coming in, and we in the centre didn't really have the infrastructure to deal with them, right? So it's like we've got to get a bit better at that. And then the final thing I'd say, and Indy touched on it, is, you know, service design. You know, you got to recognise the interconnecting parts of this. It's no good fixing a problem in one area if you're just bumping the problem down the road. We saw a lot in the, health and social care space, as others have mentioned. If you only fix secondary care, but you're moving all your people out of hospital into care homes where they're still kind of 30% paper based, then you've got a real kind of problem. And that problem, it's a system. You have to tackle it as a system level, and you do that by service design, mapping the entire service, and speaking to the users, even if that's a phone call or a Zoom call. That would be my kind of lessons from the last few months.
Very much indeed, Ian. And thank you everybody for those initial comments. We'll go to audience questions shortly. Jonathan Cordwell is very much in prime position there, so do write in. We've got capacity, we've got space to answer them. Just click on the Q&A button at the foot of your Zoom screen. I want to sort of get the panelists' perspectives on a couple of key points first, though. There's so many issues. Two of them are really obvious ones. Are what do we learn about how to create an environment for collaboration and integration at the local level? What can national leaders do to support the progress that has been made and enable organisations to build on it? There's another topic around, actually, as John was mentioning, it isn't all about COVID. We need to maintain business as usual too, so that will be the second. So we can but first we have seen such progress on partnership working at the local level. What changes at national or state level could help embed that collaboration and support further progress? We'll go in the same order if we may. John.
So I think, I may touch on that question from Jonathan, actually. I think there is something about recognizing what has been achieved locally and then trying to work out why that's right. So obviously there was a crisis, but people, I think, were also getting the space to deal with their issues in a different way. I mean, let's be honest, a large amount of funding probably helped. A lot of managers I spoke to were saying that, well, I've never had to manage in these conditions before. It's horrible, but we're getting so much resource to throw at this set of problems that it's probably an unparalleled situation that's not going to be repeated. So I'd be doing something to give the local systems the permission to carry on. And I think that will mean some of the behaviours we have seen from regulators are having to change, including just keeping backed away from the way those systems are operating, because I just don't think they've got the capacity to do the kind of transformation that people are talking about and service the old model of regulation, oversight, tight targeting, reporting, all the rest of it. That is very hard to do in any conditions, but in these conditions, I'd say is impossible. So that's the challenge to them. I think they've got to butt out.
Thank you, Heidi. It does sound a bit like California's situation. There's strong analogies with the UK, where we have national policy responsibilities, but actually at the local level, delivery is controlled by local bodies. What in your environment, how to support those people to collaborate better?
Mm-hmm. So, as I talked a little bit about how much data we were collecting, right? But the data only shares one part of the story. And I think the biggest lesson that we learned was early collaboration and building relationships with the local leaders, to have discussions about, hey, we're seeing this issue going on, we're seeing this issue over here. What are you seeing from boots on the ground, from your angle of what are the root causes? How can we best help and support? I actually spent 2 weeks on the road in some of our hardest hit counties in centralized California, as well as flew down to the border of California and Mexico to early on to meet with local level leaders. And I think that creating those relationships, even in person, walking through their ICUs where they are hardest hit and overflowing, and providing top level leadership right there and saying, hey, look, here's what we can do as a state. What do you need? And I think that really set the tone for them to be able to feel supported, but not feeling like we were taking over their work or their processes. And so I think it really comes down to building those relationships in many different ways. Yes, data is important. Yes, those phone calls and getting some qualitative information is important, but having that face-to-face, taking a flight, taking a 10-hour drive or whatever it's going to take to really show that, hey, we've got a whole team of experts here to go through what some of these root causes and issues are. What we found in California with some of our hardest hit counties were our most rural counties. And those were the ones that had a lot of migrant farm workers who were coming through living in congregate settings and having, massive, spread rates within those communities. And so really got involved with the Department of Agriculture and other departments working together on an issue, rather than people thinking that health is in this little box or this vacuum, but really looking at how do you reach out to other leaders without beyond healthcare to partner and find solutions.
Thank you. Indy, yeah, so you mentioned the maturity of integrated care systems. How can you help them grow up a bit?
Well, I'd say it's interesting. That was actually the piece I was going to come on to, was when we've looked across a number of integrated care systems now and their integrated care provider partnerships and places. That early collaboration, that willing to work together has been clearly one of the most positive parts of COVID. And there's really good singular examples of different solutions that have been put in place. But I do think from a national perspective, we probably need to be honest as to the scale of the gap. And what I mean by that is, I think that there is, what we haven't seen is the reuse of services that are actually just really good. They kind of wipe their own face when it comes to economically, but because people aren't clear who the payer is, no one really moves on it. I think we talked earlier around one of those examples around that health and social care interface, where there's just a desperate need to be able to provide solutions, whether it's around automated call handling or so forth, that actually we know it economically makes sense, we know it makes sense for the patients, we know that solutions can be delivered, but actually what's stopping it is everyone's kind of pointing to each other as to where do the funds come from. And I think in those types of instances, they may well need national to say, fine, in which case we need to go and intervene and we need to provide that investment. Otherwise, my fear is that'll just carry on. I think that the second thing related to that is recognizing that localities need the headroom, that they simply do not have the resource to be able to do what they're doing and do the transformation work and do the forward thinking, both in terms of the capacity, i.e. the workforce they have, but also in the capability. There's a whole new set of emerging technologies that are arising where the skills just aren't not necessarily there at a wide scale within the NHS. And the implementation of those types of service-enabled technologies, again, is pretty new. And this kind of went to my previous point, as blueprints are great, but actually what I think we have to recognize is they're going to need hands-on support around the implementation of that and the introduction of some of those new technologies. So what we've seen within the maturity assessment is leadership, strategy, workforce, implementation and skills are the areas that are weak within those systems. There's lots of really good track record as to point solutions, but actually if we're going to genuinely enable localities to work at pace and through a service transformed approach, I think naturally there needs to be the recognition that much more needs to be done around hands-on investment and support to some of those localities.
Yeah, fair enough. I see this problem so often, isn't it? Public sector benefits as a whole, but who's actually going to put that investment in to generate rewards which are accumulated to other organisations often? Ian, your thoughts on what we can learn about, what we can change to support that collaboration?
I mean, between the centre and the regions, or between us and the private sector, or? Well,
our audience are civil servants at national and state level. So yeah, what's within their areas of responsibilities?
Yeah. Look, I mean, I think it's very difficult, isn't it? I had an interesting chat with a very successful regional health lead in the north of England yesterday about, finding the right balance between central and local. I think in my experience, most of innovation happens like closer to the front line, where stuff is, right? It'd be driven out of necessity or opportunity or whatever it is. You know, it's closer to the users, which is something I passionately believe in. So, you know, it's going to be very difficult. You have to kind of facilitate that. If you're in the center, you have to kind of support that. So then you have to ask yourself, well, what is each bit good at? Or even more, you know, what are the bits that only we can do, right? So, you know, we have in the center, you know, access and the ear of the ministers. You know, we have access to significantly more funding than probably out in the regions. You know, we have policy levers. You know, we can make things happen by, you know, just changing. In fact, one of the biggest, you know, most significant things we did in wave one was to engage with the Information Commissioner and the National Data Guardian and say, you know, would it be okay if we sort of publicly relaxed the rules a little bit or encourage people to, you know, err on the side of sharing data as opposed to err on the side of never sharing data in case I, you know, feel the full wrath of the law. Would it be okay if we encourage people to share data if it's for the benefit of someone's health? And they said, absolutely, of course it is, you know, and they publicly got behind that. Now that makes a big difference if you're on the front line, you know. We can do that in the center. So it's a silly example, but it's a kind of example of, you know, working out who does what because they're best placed to do it, and sort of not bun fighting over the bit in the middle that we both want to do. I don't know if that makes sense.
Yeah, great, thank you. And just on this topic of, you know, essentially business as usual, you know, restoring a full range of services, improving public access to, you know, remote consultations, etc. So we make sure there's sort of universal access to that, repairing the damage to organisations. What can national and state level actors do to support you know, that, catching up with those backlogs, plugging those gaps at the local level, or change the order of things? Perhaps, Heidi, can we ask you that question?
Sure. So when you say, you know, business as usual and return to normal, I was just kind of taken aback because right now we're entering our second wave, and that is so far from our minds right now, to be quite honest. And right now we're really focused on not only going and making it through this second surge in California, but also looking at how we're going to operationalize vaccine distribution when the vaccines on the market that look to be the first ones available in America are ones that have operational and implementation challenges. And so that's really where our mindset is at this point. And I think that, you know, as we look to operationalize vaccine distribution, we're going to be focused on some of our, you know, current lessons learned about working with systems, sharing resources across departments at all levels. And that includes workforce, that includes technology, that includes making sure that we have equity when we're looking at health equity and access to vaccines, and equity and access to healthcare during the second surge. I think if we're looking, you know, in the future with a crystal ball, what does that look like with potential backlogs and how do we assist? I think for us, the biggest issue is workforce. And really, how do we shore up and make sure that we have systems in place to support our workforce at all levels? I know that we've already had work underway to focus on building up the next generation of healthcare workers and working with our community colleges and nursing schools to start getting that next new batch of staff ready to graduate and be prepared to take over next year once we have a whole set of clinicians who might honestly need a break after these last couple of years.
Yeah, thank you. And obviously, I wasn't meaning to suggest that, you know, it's in the rearview mirror. I suppose what I was thinking is that, you know, as vaccinations do come through, you know, you start to be able to have less constraints around, for example, you know, separating COVID and non-COVID patients. And we'll come back to vaccinations actually perhaps towards the end. But I suppose other things that national and state actors can do to help local providers, restart elective surgery, for example, make sure that everybody does have access to primary care for the next sort of 6 months until we start to get back to normality. Perhaps I go to Indy.
Yeah, so I think this is where generally there is an opportunity around the use of data and digital solutions, but as long as they're embedded as part of that service change. So one of the things that came out of our recent assessments, but also some of the other work we're doing, is that need in primary care to recognise as a significant shift in the workforce model. So from COVID, actually much more left shift, much more need for skills and community and primary care services. Well, in which case, what are the digital workforce solutions that you can use that are out there to be able to really understand the demand and the types of workforce that you need? So whether it's primary care insights or other types of tools that are now on the market, but actually that really allows you to be on the front foot around the future workforce needs that you'll need to serve. In the same way, really thinking about how you can use some of those data insight tools, be it around planning for elective demand and the different the different solutions that are out there. So the work I mentioned around Cheshire and Merseyside, again, around being able to understand what the waiting lists are, what's the predicted demand, what's the current demand. So I do generally think, and it kind of goes back to that earlier point of where there are good points of practice, how do we look to proactively nudge other localities that may not either be aware of them or don't have the skills yet to come up with those, to be able to harness some of those digital and data solutions? Because ultimately we're going to have such a constrained workforce that we need to be able to give them proven off-the-shelf solutions as much as possible to be able to help them.
Yeah, thanks. Ian, to you.
Sorry, Matt, can't off mute. Yeah, look, again, I mean, repeating everything everybody said, I think it's, this is an interesting one, right? Because it's partly about embedding the gains, as everyone said. There has been some changes to the way services delivered, and some of those changes have been, have improved efficiency. However, that comes at a cost. I imagine a GP rattling through, hundreds of phone consultations in a morning probably feels a bit, to Heidi's point, pretty exhausted by the time it gets to lunchtime, right? So that's a great it's a service transformation, but it's kind of unsustainable. So how do you make it sustainable? How do you give them the tools and all users the tools to kind of make sure that you're optimizing the service journey? I mean, one of the things, again, going back to my experience in the private sector, that I think we haven't yet tapped into in the public sector is the kind of self-service model. My bank gets me to do a heck of a lot of work on its behalf, including kind of remortgaging my house, via my mobile phone. So, there's a whole model there that says, if you make it possible for people to do things, they will, and then you can relieve pressure that way. So exploring some of that. We've made some pretty sweeping changes to services. Try to go to one of the 50 emergency departments that have currently rolled out the online triage and booking solutions. 75 years of people going to emergency departments when their kid hurts themselves, or when they cut themselves. We're trying to change that behavior now in one fell swoop and introduce online tools and triage. That's a huge change. It's going to have benefits, but we've got to do it in the right way. But I think the job of the centre is to support all of that transformation in the best way it can, whether that's through Jonathan's question about the procurement stuff. Definitely, the centre has to get better at supporting the procurement side of things, whether it's about standards and standardizing, whether it's about the blueprints, as Indy says, whether it's about kind of finding pockets of fantasticness and then not just pointing at it and saying, oh, look at that, wouldn't it be good if you did that, but working out what an actual scaling model is, because no one else can do that, only the centre. So I think that there's tons of opportunity.
Thank you. And John, come to you on this point.
Yeah, I mean, I wouldn't disagree with anything, and I think there is, you know, the centre's role is clearly to do what only it can do, and I think the problem is the centre has also done a lot of other things over the years, and the risk is it sort of tries to ping back into that you know, shape. Some of the demands I think being made on the recovery, I was really interested in Heidi's surprise about our ambition to manage the second wave and start the recovery and do winter. Is, I mean, it's almost very telling, but I think that the need for us to look at what has not been done in the last 9 months and see if we can continue not doing it is actually really important. And I'm talking about the kinds of service demands that are made on local systems by, you know, NHS England, Improvement, other regulators. You know, we're still in a crisis, so let's still keep some of that crisis mode going, and I think that's going to be really important. I think on the workforce stuff, you know, clearly what you ask the workforce to do will determine how sustainable it is. I mean, one fear for a lot of managers is that people will manage their need for a break, not by taking a break, but by leaving the service. And there are lots of, you know, there's lots of anxiety that once this has gone on for long enough, people who can afford to do so will start thinking about, you know, taking their retirement earlier or just leaving the service for other work. And I think things that the centre can do to help support people, particularly around health and well-being. And one of the things that's been done really well are national offices, often digitally delivered, around health and well-being services for staff. And I think things like that in the next few months, I think will be really important. I think the accent has to be on hands-on right now rather than things you might be able to do in a year's time. And I think the support for individual managers, particularly if that can be done more digitally, I think would be an absolute win. But they need it now. It's not a case of let's develop some programs for a couple of years down the line. So if the centre can do things like that, then I think that could really help with the workforce challenge.
Great, thank you. You've neatly mostly answered Philly Adams' question. The Royal College of Nursing say that 30% of our experienced nurses will take early retirement after this bout of COVID-19. For me in workforce, they are our go-to staff. They lead calmly and help mentor students. What can be done to keep them in the system in a way that we don't overstretch them and carry on doing the same thing? So just broadening that a little bit beyond nursing staff to consider frontline health and care professionals. John, is there any other further comments to make on that question?
Well, I think it goes back to flexibility. So if people are complaining about the pressures, the strains, then instead of the whole of them leaving the service, how do you keep some of them in the service? So, you know, is home working, part-time working, flexible retirement plans, different duties, redeployment, you know, all of these things, which probably with a good information stream, you could manage more across the system. I think those are the kinds of things that, you know, need to be supported. And the sort of the ICS model has a really tiny workforce capability at the moment. You know, the capability on workforce is in the institutions, in the system, rather than at system level. And I think that could be an early thing that needs to change, that you build a sort of system capacity to help manage deployments and really attract people to stay as well as to join the service.
And just to add on to that, Matt, if I may, I think there's when we talk about workforces, to talk about that holistically. So there's clearly the frontline staff who've just been at it constantly. There's also probably those involved in delivering the digital and data solutions that have been on call or manning service desks at midnight. And so, you know, there is a fatigue across a range of different workforce skills. And I still think there is a concern that, you know, if you look at the digital and data workforce in the NHS, you know, they're still comparatively in terms of pay, there's kind of, you know, actually where they sit organisationally, but also their skills and development. At the same time, they are now being asked to consider completely new technologies and new innovations, and, you know, as Ian was saying, you know, self-service, new ways of delivering initiatives. I think there has to be something that recognises that, you know, when you think about workforce, that next generation is going to take some time to come through. What you can't do is do nothing during that intervening period. So how do you supplement, mentor, coach, provide assistance to those folks as well?
And I appreciate that when you talk about workforce, you're also expanding that to the digital and the behind the scenes staff who've been working nonstop for these last 11 months. Because I think so often people, when they think of the healthcare workforce, they're constantly thinking of those first responders, the clinicians, but I know my data team is working 7 days a week, just as hard, and they are just as burnt out. And it's about also creating rotations, backfills, making sure that they know that when they are offline, they're complete offline, and they have someone else that they can trust that they can hand off that work to seamlessly. So I think for us, it's been about building sustainable structures of staff behind the existing staff so that they feel like they can truly get a break and make this more of a sustainable way to work.
Thank you. Ian, do you have any comments around this? I mean, presumably some of the, in some ways, remote consultations, for example, provides the opportunity to change people's job roles and make working more flexible, etc. Is there ways that you can see to relieve some of the pressure on staff and make sure they keep them in the workforce?
Yeah, look, I mean, I would say there has to be, right? I mean, unfortunately, I'm not an expert in the, Californian health and care provision, but I know most people in this country will find that, whatever they're issued by their local IT department is purpose, some of the services that they have to use, whether it's kind of HR or finance or, things like that, just drain on their time. As you say, there's ways of working, new ways of working that could be more efficient. I think there's loads of opportunity there, but I think the first step, and others sort of mentioned it, would be to go and speak to them, find out. Don't sit in the center and try and second guess what they need, because it'll probably miss by a country mile, and then you'll be in an even worse position. So let's go and speak to them. Let's find out what it is that they did in the peak of wave 1 that helped them to get through it, because maybe there's some nuggets of things we can build on there. Let's ask them, what do they want? What would make your life easy? What would make you stay? So yeah, for me, there's definitely opportunity, but let's not try and work out what it is sitting in the center.
Thank you. Well, from the centre, it's quite a good position to get a perspective of what's happening internationally, at least. Justine Schneider thanks Heidi for her really valuable insights from California, and points out our friends and neighbours to the east of the UK had a head start in tackling the pandemic. I don't know if you put it like that. I mean, that we've seen huge differences in countries' performance during the pandemic. Some have minimised both the health and the economic damage, and others, including this one, have suffered very high levels of damage on both fronts. What have you seen that might explain, what's made the difference? What have the poor performers have to learn from the best? And I suppose both covering health and care services and wider public health services like testing, tracking and isolating. Can I come back to you, Heidi?
Sure, we can start there. Well, it's interesting. I think that there's, even research is starting to be done on political systems and cultural systems within countries, how their healthcare and public healthcare is messaged has a big part in how a non-pharmaceutical intervention is really going to be either embraced or not embraced by the mass public. And I think for America, it goes without saying, we've had a lot of mixed messages on a national level here, which really caused some severe issues with compliance of mask wearing, compliance of social distancing, and even believing that this is something to be contended with in a real serious way. And I'm always a big believer of you have to control what you can control, and you can't worry about the things you can't control. And there were a lot of things that we could not control at a state level for a federal response early on in the pandemic in America. And so I will have to say, at least our California state leadership was definitely very science-based, very much so focused on, doing one of the very first mask mandates and a lot of the different MPIs we put in place. But I think it really is not just about your public health sector, but at least for us as a country, it depends on what the political and public message is about public health, and what are those measures that need to be taken for not just yourself, but being mindful of your community and to minimize the spread.
Yeah, thank you. I mean, it's the level of cost and harm suffered by countries is so vast. It's kind of like war level. So you think you could sink vast amounts into preventive work, and it would still be a really good bet. But actually, as you say, so much of it is about messaging and the public perceptions. John, what do you think we can learn from more better performing countries about it?
Well, I mean, you've kind of one thing we could learn is prevention just costs less. And I mean, we have, we will have spent by the end of this sort of financial year nearly 2% of GDP on PPE and testing, which is to manage this particular crisis. We'll probably spend about half of that next year, and that's before you get into long-term transformation of healthcare. I suppose those countries that have been successful in some ways did have early experience of pandemics. The SARS experience in East Asia clearly prepared both public and policymakers better than arguably it was here. I think those countries in Europe that seem to have done well have also kind of got federal structures. So there may be something about how much is left for the centre to do. Heidi's point, if the centre is saying the wrong thing, you could mitigate that a little bit by having a more federal structure where different players can come in. I do fear that in our country we may have simply hollowed out some of the planning and the thinking too much, and that we've run our infrastructure, certainly around health and care, too hot for too long, that something like this comes along and it simply cannot cope. And therefore, one of the things that maybe we need to think about is running the system less hot and building the kind of capacity within it. Everyone always talks about German success around testing because they just have so much testing capacity and started with it there, whereas we have been trying to event it as we've gone along in the crisis. And I think that's, if you think of all the public sort of confidence damage that's been done around over-promising and under-delivering on testing, I think creating the infrastructure is going to be a really high priority. And those countries that have it, for whatever reason, whether it's pre-experience of pandemics or just because they've always built it in, seem to have done better.
Yeah, thank you. Indy, any comments on this one?
Yeah, it's interesting actually in terms of kind of the three main bits I'd cover off. Firstly, I think is around messaging. And actually we went through a lot of this, but on a much smaller scale when we were trying to support and enable information sharing across health and care. Public trust is fundamental, and the messaging that you have around that isn't something that you do just once. You have to perpetually and continually reinforce that set of messages, and I think this is where actually a lot of the transformation that we're trying to support is as much the social cultural transformation side than it is the hard-nosed technology, and actually sometimes there's not enough focus and investment around that side. Actually that's where using effective change methodologies or actually approaches around that I think sometimes gets overlooked. I think that the second part around that, and it's interesting because where I kind of came from, kind of on the architecture of healthcare, was kind of always looking at the digital data solutions. The operating model of actually who does what, when, and how, for me is becoming even starker when you're thinking about the current pandemic, but also as you're moving into this complex situation where you'll then have to tailor on the service change as well as the continued delivery in wave 2 and wave 3, and again actually having the specialist focus on actually who needs to be doing what at what level and what are the roles and responsibilities and the clarity around the messaging of that. But then also, which comes the third point, is the effective resourcing to be able to do that. If you just have the right public messaging and you don't have the operating model, then you don't know how you need to execute. if you have the public messaging and the operating model, but not the effective resourcing of that, both with skills, capability, and funding, so forth, you're not able to execute it. So I do think you need kind of all those three pieces.
Thank you. And Ian, did you see anything overseas that you thought, oh, grab hold of that, that's really working?
Did we see anything overseas? I mean, in general, we do. You know, whenever we're undertaking a sort of transformation, we look around. I know it'd be pre-COVID, so not particularly related to COVID, but pre-COVID, we were undertaking sort of transformation of our cancer screening services. And, you know, if you look around the world, there's plenty of countries that have kind of are doing things that we could learn from. So I'm always up for that, you know. I think, I mean, in terms of learning, I mean, my hope is that we actually carve out the time to do some, you know, when appropriate. But, you know, let's, you know, if this was a digital transformation project that I was running, you know, we would be, you know, we would have had, well, we did, in fact, amongst my team, we had a retro in July when things were a bit slower. You know, what did we learn in wave one that we're going to change for wave two? So I hope we build in the time for people to do that, and then to share those learnings and those findings from other countries, from the neighboring borough, from their own organization. You know, I'm sure there's stuff we can learn.
Thank you. We are nearly out of time. We've got just one more question, which I wanted to ask about vaccination. Essentially, you know, bearing in mind everything we learned so far, just one like key thing for us to bear in mind as we design and deliver the systems for mass vaccination. And I also have to mention Jonathan Caldwell's question. We kind of touched on the structural stuff, but we didn't. Do you believe the UK will be able to retain some of its accelerated procurement best practices, or will we revert back to the norm? On that question, of course, we have to note that this accelerated procurement does mean throwing a whole lot of money out the door very quickly. Plainly, not all of it has been well spent. So really the question is, how do we maintain the pace whilst devising new ways of addressing the risks that the original system was designed to prevent?
Yeah.
Who wants to go first on that? We've got kind of a minute each.
I mean, I can definitely say something on that, because it's, you know, having been in the private sector and then moved to the public sector, I had an interesting conversation the other day where, you know, we were talking about kind of bringing in, you know, support contractors, and someone said, you know, we've got it down to like 3 weeks. And I think, my goodness, like 3 weeks, you know, in the private sector, if I needed someone because we, you know, an extra developer or something like that, you know, they would be in the morning. They might even be in overnight, you know. So, you know, we need to get that bit right. And yeah, certainly in wave one, there was, you know, a massive relaxation, and then a kind of response. You know, the elastic band pinged back, and it sort of pinged back too far. And now it's like, you know, as you say, you know, there's lots of evidence of money not being spent well. I'm sure there's evidence of money being spent well as well, but we're focused on the not well. So we have to get that procurement bit right, because it costs money to spin your wheels and wait. So, you know, the idea that by slowing down the procurement, you're somehow saving money, not always true. So for me, yeah, we have to nail that bit, and we're a long way from doing it. But, you know, we're trying.
And on the vaccinations, is there one key priority thing people should bear in mind as we work out to do this?
Speak to the users, you know. Get out there, speak to the people who are going to be sticking the needles in the arms, speak to the people who are going to be driving the, you know, stuff to the locations, you know, speak to the users, you know, in all of this. Where's the data going from and to and how, and, you know, yeah, get out there.
Thank you. John?
Yeah, I mean, I think the procurements, I mean, it's not so much the speed of it as the process. And I think, you know, clearly the pendulum swung one way, and we need to stop it before it swings all the way back. But I don't think we can simply say, you know, we want to keep the procurement system as it currently is, because it's public money and there will be political questions asked that may not be asked in other contexts in the private sector. So I think we just need to make sure that there is a degree of process that gives confidence, whilst, you know, not slowing everything down to the point of uselessness. I mean, on vaccine, I think the thing that concerns me the most is the message to the public. And I mean, I'm not being entirely flippant, but I'd probably put body cams on immunologists so that everyone could see them having their vaccine, so that their confidence levels rise as quickly as possible. And I'm thinking most importantly in the workforce as well. I mean, the group that we want to see vaccinated quickly is the workforce. So concerns need to be not sort of shoved aside or belittled, but dealt with head on, so that we get maximum confidence quickly amongst, you know, frontline clinicians in whatever vaccine we choose to roll out.
Thank you. Heidi, your sort of priorities as a look towards vaccination.
Yes, and I do want to speak briefly on procurement as well. For us in California, the biggest issue with procurement was trying to have procurement of enough testing swabs and testing kits. And the way that we ended up solving that in California was stop having to be dependent on national stockpile, and instead we created our own lab in California that soup to nuts manufactures everything from the swab to the kit to the chemical assays, so that we could completely control the entire manufacturing process of our testing. And we just did that this fall. That's probably the biggest lesson that we took back, was we need to be self-dependent and be able to create what we need for future. When it comes to vaccines, I completely agree with some of the other panelists about public trust. We will be vaccinating our healthcare workers first. They are our first priority. They will have the first set of vaccines to model the way. But building that public trust is going to be incredibly key in getting the mass public afterward vaccinated.
Thank you. And Indy.
Yeah, I mean, just echoing some of the comments that have come before, you know, I think it's actually probably a broader theme than just about around thinking about the end-to-end service design, procuring not for bits of tin, but for procuring for actual services that you can deliver. So again, taking some of those key learnings from the pandemic, but also thinking much more holistically as to how we deliver this in a way that's got clear public messaging as well.
Great. Thank you very much indeed, everybody. We are out of time. I hope the audience have found it useful. I hope the panelists have enjoyed it. Thank you so much to all our panel, Ian, John, Indy, Heidi. Thank you also to PA Consulting for sponsoring. Thank you to the audience for watching. We will be publishing a report on this event in the next couple of weeks, and we'll email you then. And meanwhile, thank you very much indeed. And shortly, Maria will press the button and will disappear from your screens. Goodbye.
Thanks all.
Thank you.